We are going to be talking about PCR management with premium IOLs. This is a case-based scenario. Let's talk about the first case in which I am doing an irrigation aspiration and we get a PCR out here. At this stage, we put in an OVD to prevent the AC from shallowing and tear from enlarging. Now here we are using a technique in which we are feeding the flap to the forceps, the micro-axis forceps, and we create a PCCC without any vitreous loss. All this while the tag is having a fluttering sign, and that signifies that there is no vitreous which is coming to the AC through the PC Revit. Once we've done that, we put in an IOL carefully in the bag, and this is a Toric IOL which you can position as per your axis, which has to be aligned. And we go over for the next case now. Here we have a defect which is nearly 1/4 of the PC not being available for the support of the IOL, and now what are we going to do? We insert the IOL, we let the IOL open up in the chamber, not directly into the bag, and then slowly manipulate these haptics in the area wherein the PC is intact. And once we've done that, we align the IOL and then lift the IOL up to have an anterior optic capture. These are common cases like posterior polar cataracts, and this was in fact the previous eye which was operated did not have any rent, and we were expecting and hoping that this wouldn't be having a rent either, but we had to treat it like a PPC, so we aimed at a smaller axis size of around 5 to 5.2 millimeters. We did a gentle hydro dissection in all the quadrants, not a gentle hydro delineation, not a hydro dissection, and there was no rotation which was done for the nucleus. Cleaned the epinucleus without rotation, without disturbing the central plate, and then proceeded with the bimanual irrigation aspiration. Loosened the cortex in all the clock hours, again without disturbing the central plate. But unfortunately, not all PPCs behave themselves, and you can see that a PC defect was already noted. OVD was used so as not to allow the PC defect to increase. This was a dispersive OVD. And then we completed the rest of the irrigation aspiration of the cortex. With minimal fluctuations in the chamber. But this is where the unpredictable nature of a posterior polar cataract is seen. You can see that the entire half of the PC is absent. Now this is a patient with a Panoptix to be put, a Panoptix Toric. Now we've already seen the axis and decided which axis it is to be put in, and in roughly that direction we rotate the IOL and then start manipulating first the trailing haptic is nudged into the bag, and then the leading haptic is nudged into the bag. But here I have a feeling that the haptic is probably not in the bag. So I shift over to a better contrast visualization, which is the monochrome filter on the Ingenuity, and here I come to see that okay, the haptic is actually not in the bag. So the haptic is gently manipulated into the bag. All this while there has been no vitreous which has come into the chamber. That's because of maintaining the chamber at all times and with minimal fluctuations that we have been doing. Once the IOL is positioned, we do the reverse or the anterior optic capture for extra stability. Once the optic capture is done, we confirm that the IOL position is proper and the axis that it has to be done placed. Check for IOL stability, do the irrigation, aspiration and removal of the OVD and form the chamber without allowing again the fluctuations in the chamber. And here you can see that the axis is very well placed, the IOL, and 3 weeks post-op, well placed. This is the right eye which did not have the PCR. So to summarize, we need to aim at a smaller CCC. PCCC is an important art, and anterior optic capture also is important in these kind of scenarios.